Welcome to Ageless and Outrageous, your favorite podcast about how to age amazingly. I'm urogynecologist and hormone and sexual health expert, Dr. Kristen Jackson. Every week, I share my over 25 years experience to guide both men and women as they age. Listen as I discuss a variety of topics, including hormone optimization, pelvic floor health, maintaining a vibrant sex life, weight gain issues, and skin, hair, and body changes as we age. It's happening to all of us, so listen for some solid scientific knowledge on how to handle these changes. Tune in for a dose of laughter, knowledge, and an honest perspective on the incredible adventure of growing older. Today on the podcast, I realized I wanted to talk about something that I probably should have done the very first day I started my podcast, because it's a question I get asked in my practice so often. And that is, what is a urogynecologist? There are so many misconceptions about the subspecialty, and many women don't even know that this type of practice exists. But this is a field that I have been working in for over 20 years, and it's a field I am so passionate about, and I want to make sure that people really understand what a urogynecologist can do for you. Urogynecology is one of the newest board-certified subspecialties. We are physicians who specialize in disorders of the pelvic floor. Most urogynecologists come from a background of OBGYN training, but you can also have a background in urology, and then either way, you do additional subspecialty training on the female pelvic floor. Urogynecology only became a board-certified subspecialty in 2013. That's the first time you were actually able to sit for an exam and attain this additional specialization. But many physicians were practicing this type of medicine for years prior to the formal exam. And many of those older physicians chose not to sit for the examination. One of my mentors, someone who was in my current practice before me, was one of the leaders of the field of urogynecology for many, many years. And he ended up retiring in 2014. So he would often say, I know more than any fellowship-trained urogynecologist, but I'm not taking the time to sit for an exam. So I think a lot of those original pioneers of urogynecology may not have ended up board certified because they were later in their career and they just didn't want to go through the hassle of sitting for the exam. Because in order to qualify for sitting for the exam, you had to create a log of all your experiences and your surgeries and submit it to the board to make sure you qualified to sit for the exam. So when the certification initially came out in 2013, you had 3 years to take the exam and pass it before you had to be fellowship trained. So they would look at your caseload, you would submit a list with all of your cases for a year or more. They would make sure that your experience was wide and vast enough to qualify as a urogynecologist, and then they authorized. And they're actually really thrilled to hear that we're here to help them. But the second most common thing I hear from patients is that they think a urogynecologist does all the things a gynecologist does and all the things a urogyn does. Or they think they do all the things a urologist does and all the things a urogyn does. But urogynecology is actually a subspecialty of both of these fields. So even though I am personally trained to do all things OBGYN, my current specialty focuses only on diseases of the pelvic floor. So in my practice, I don't offer routine GYN care like pap smears and mammograms, treatment for vaginitis, things like that. I also don't treat patients for common urology complaints like kidney stones or prostate issues. Those are the type of things I'm going to send out to the urologist. So even though I am board certified to perform all OBGYN procedures as well as all urogyn procedures, I choose to focus on that subspecialty because there's such a need. We actually meet and they'll say, I drove over an hour to get to your office, and I will know they didn't pass any other urogynecologists on their way. So it's not like they're picking me out of a large group of urogyns. They're coming to the first available urogyn that they can find. The next most common thing I hear from my patients is, how did you become attracted to this field? And I will tell you, patients always ask this question as they're scooting down on the table for their pelvic exam. They put their feet in the stirrups, they start to scooch down, and they make some comment like, I can't believe this is what you look at all day long. And I'll tell them, I am so passionate about women's pelvic floor health. I love what I do. And I love enhancing women's lives and their sexual health and their hormone health and all the things that I do in my practice. But I have always personally been interested in vaginal health and vaginal surgery, even when I was training as an OBGYN. When I finished my OBGYN residency, I remember my residency director had an exit interview with us, and he asked us to rate our program, what was great about it, and where they could do better. And even at the time, this is back in 2001, I told him that the thing I really felt was missing from my training was about the pelvic floor and bladder health and pelvic organ prolapse. So at that time, there were no board certified urogyn fellowships because the subspecialty didn't even exist. So in my personal career, I really had to seek out that training on my own after my residency by studying with experts and leaders in the field. Now, of course, there are urogyn fellowships that OBGYNs enter after residency training. But a lot of times we joke in medicine that you go into your chosen field simply because you can handle the fluid that comes out of your area. So I am not at all bothered by vaginal discharge or menstrual blood, but I don't want anything to do with sputum or oral secretions. So I know I could never be a pulmonologist or an anesthesiologist. I don't want to be anywhere near that type of sinus secretion, but put me between the legs and anything that comes out from there, I'm fine with that. I can't tell you how often I'm in the operating room and I might have a patient with very severe prolapse. So her uterus is completely hanging out. And sometimes the anesthesiologist will come down from the head of the bed to get a look at the anatomy before we start. And they make a face like, oh my gosh, how do you deal with that all the time? That's horrible. But then at the end of the case, the anesthesiologist is removing the tube from the patient's trachea, and often it comes out with this big long line of sputum that pulls out of their mouth, and I just have to turn away. I'm like, "Oh my gosh, how do you do that all the time?" So I think most physicians find the bodily secretion that they can handle and they run with it. But besides being able to handle the fluids that happen, urogynecology makes such a huge impact in women's lives, and that is what makes it so completely fulfilling. Now, another thing that I spend a lot of time teaching my patients is what is normal about their vulvar anatomy. I've commonly said that women never get a good education on what normal vulvar anatomy looks like. And so I really try to take the time to show patients what is normal and what's not. So, since most female anatomy is internal, women don't have the opportunity to check out other women when they're in the gym or a locker room like men can. So, I always tell women they only have the opportunity to really examine one set of labia, and that's their own. Whereas in my career, I've probably examined over 10,000 sets of labia. And the most common theme I see is that there is such a variety of normal. It is rare that I tell a woman she has an abnormal vulva unless there's actually a medical condition with it, like a Bartholin cyst or a lesion that shouldn't be there. Most women are concerned that the shape or length of their labia is abnormal. And there are two sets of labia. The outer labia have the fat and the hair, and the inner labia have no hair. And somewhere along the way, society decided that the inner labia should stay tucked inside the outer labia. And while some women do have this configuration, by no means is that considered the only normal appearance. Plenty of women have inner labia that are longer or more prominent than their outer labia, or they stick out beyond the outer labia. And this is completely normal. People have varying degrees. So the only time we would recommend fixing it is if the labia are really long. So they're getting caught in your underwear or they're uncomfortable to exercise with. Sometimes, if you're a biker, you can't sit on the seat properly if the labia are really long because they get in the way. The other common thing I see is that one side of the labia may be a little bit bigger than the other. And this is not just common with labia, this is common everywhere on the body. So sometimes one breast is larger than the other. Some people have one foot larger than the other. It's just common. Humans are not perfectly symmetric. But again, if it's bothersome or interfering with your positive body image, then we might proceed with some surgery to correct that. And then there are some women who I think are surprised if all of a sudden they decide to do some aggressive grooming of their pubic hair, the labia are suddenly visible to them. It may be that they've never really taken a good look at the labia underneath their pubic hair. So they trim it or and they'll come in and they're very nervous. And sometimes we have to tell them, no, that bump is actually your clitoris, or, oh, that bump is actually your urethra where the urine comes out. So they've just never been given a good education about what is normal. And I really love to be able to empower women and tell them what's normal about their anatomy. One of the best lines I ever heard was that there are as many vulvas as there are faces. So no two faces are exactly alike. It's probably that no two vulva are exactly the same. And once you've seen 10,000 plus vulva, you really know that to be true. I do have some patients coming in and they may want a surgery for a cosmetic change to the vulva. But I always try to remind them that the labia minora, or those inner lips, have a lot of nerve endings and a lot of positive sexual stimulation. So, reducing them too much or cutting them away altogether is going to rob those women of the ability to be sexually stimulated at the level of the labia minora. These are not just useless pieces of tissue hanging around the vagina, they have a function. So, you don't want to routinely be making them smaller or cutting them off just to fit some standard of the labia should stay inside. So, as a bladder expert, another thing I get asked about a lot is what is normal or abnormal in terms of bladder habits. Women don't know how many times a day they should be urinating, or if they should be getting up at night to urinate, or is it normal to leak after they pee, or at any other time. So, let's describe what normal bladder function is. The first thing, of course, is that we need to urinate. Our bladder is just a vessel that is meant to store urine until it's the right time to let that urine pass. And our bladder has a defined capacity, so we have to empty it before it reaches that capacity. Urinating about 6 to 7 times per day is considered normal. So that would be urinating at least every 3 to 4 hours. Going more frequently than that, specifically going more than every 2 hours in the day, can be abnormal. And on the opposite side, holding your urine repetitively for longer than 4 to 5 hours can be abnormal. My biggest offenders on that side of the equation are teachers and nurses because they work these long shifts and very often they will urinate just before they start off their shift. And then they really don't have the ability to go to the bathroom for the next 8 hours or more. So even though they're getting that sensation to urinate during their shift, they're delaying it. They're pushing it away because they're too busy. And what that does over many years is stretch your bladder out because it has to hold more and more urine and it blunts the signal that tells your brain you have to urinate. And that's what we call teacher bladder or nurse bladder. So, what happens years later, after a whole career of this, is that you can develop something called overflow incontinence, where the bladder is stretched out like an overstretched water balloon and it doesn't push the urine out. So, you start leaking out randomly because your bladder is never fully empty. So, if you know any teachers or nurses, please send this podcast to them and tell them, please find time to urinate at least every 4 hours so they do not work themselves into a condition of overflow incontinence. The next thing I want to teach people is how to urinate properly. Lots of grandmoms and moms teach their young girls to keep their butt raised up over the toilet seat, especially when they're urinating in a public restroom. I know my Nana was fanatical about that. But repetitively hovering or squatting over the toilet while you're trying to urinate also interferes with normal urination. So the correct way to urinate is to sit completely down on the toilet seat, feet on the floor, and your butt fully sitting on the seat. Your body should be relaxed in order to properly empty. There are two sets of muscles that have to work in the correct sequence. First, the pelvic floor has to relax. This is going to open up the muscles to allow the urine to pass out. The second thing that has to happen is that the bladder muscle itself has to squeeze. This actively pushes the urine out and gives you your flow. So if you're hovering, you're keeping your pelvic floor tight. So when the bladder goes to squeeze out the urine, it's trying to push it out through a tight little opening. And again, over time, that can interfere with proper urination and proper bladder emptying. So in my office, we have a mantra: cover, don't hover. No matter how much toilet paper you got to put down on the seat to feel like you've covered it, or use the toilet seat covers, sit all the way down on the toilet. And as a side note, our skin is actually an excellent barrier against infection. So while no one likes to sit on a wet toilet seat because it feels disgusting, there really is not a risk of you getting an infection from it. So if you have to clean off the toilet seat or cover it with toilet paper and then sit down, make sure you are fully sitting on the seat in order to urinate normally. Let me move on to urine leaking. A lot of women want to know if any amount of leaking is considered normal because a lot of women bring this up and they kind of shamefully bring it up like they're embarrassed. They're starting to have a little bit of leaking. They're starting to rush to the bathroom and maybe not quite make it in time. And very often they've been told by their family or friends or even their doctors, well, you're getting older. Yep, that's what happens when you get older. In a properly functioning bladder, no type of urine leakage is considered normal. And unfortunately, as I just mentioned, there's still so much shame around urine leakage. Women don't discuss it with family and friends. It's not commonly discussed in the media, but it's happening so frequently. Up to a third of women begin leaking after their first vaginal delivery. So that's a huge number of women. You'd think this would be a very common topic to talk about. And as we age, it becomes even more common in both men and women. So, although nobody enjoys it, it's just not something that's still kind of on the top of our radar. But we do have a lot of options to treat it. Now, as women get older and they start to have a little bit of leakage, I've heard women tell me that a lot of doctors told them it was their own fault because they haven't been doing their Kegel exercises properly, when in reality, that is not the case at all. It's actually related to your pelvic floor weakening or an overactive bladder or something that is beyond your control. So let's go through some of the more common types of urine leakage. The first one is called stress incontinence. This is when a woman puts a stress on your bladder from a cough or a jump during exercise, and that pressure on the bladder causes the bladder muscle to open and they leak. When stress incontinence gets more severe, sometimes just a little pressure on the bladder will cause it to leak, like bending over to pick up something or to tie your shoe. The other common type of urine leakage is called overactive bladder or urge incontinence. This is when women constantly feel like they need to go. So they're rushing to the bathroom too frequently. They're leaking before they can get there. Sometimes it's just a few drops. Sometimes they can get full bladder loss before they reach the toilet. Or they might be getting up several times at night to go to the bathroom. This type of urine loss is caused by uninhibited or contractions of the bladder muscle. So if it's just a little spasm, you might just have a sense that you suddenly need to go. But if it's a bigger spasm, you're actually going to start emptying out the contents of the bladder. Some women have mixed incontinence, which means they have features of both stress and urge incontinence. So, stress incontinence is a type of urine loss that many women start to experience after having a baby. There's so much stress and trauma that happens to the pelvic floor during a vaginal deliveries. Those muscles go through incredible changes. The nerves go through a ton of trauma. And there's a lot of ischemia, which is lack of oxygen, to the tissues during that time when the baby's head is passing out under the bladder. So, immediately after vaginal delivery, you can imagine that a lot of these muscles and nerves around the bladder are really in a type of shock. They're not going to work very well. So, if you start to experience some stress incontinence immediately or shortly after having a vaginal delivery, my first recommendation is just give it some time. Your tissues need to heal, those nerves need to start firing correctly, and we need the muscles to recover from the injury they just had. The next thing I would say is that it pains me that pelvic floor therapy is not a routine part of postpartum care. If we do a surgery on any joint, a shoulder or a hip, it is automatically expected and covered by insurance that the patient goes to physical therapy afterwards to get maximum function from their joint. But women are routinely going through this massive trauma to their pelvic floor at the time of the vaginal delivery, and then not being taught anything about recovering from it and not being recommended to see a pelvic floor therapist. So I would love it if it was automatic that 6 or 8 weeks after a delivery, every woman goes through treatment with a pelvic floor therapist to help bring those muscles and nerves back to their best strength and function. But overall, I would say if you are 3 or more months out from any delivery, whatever you're left with in terms of bladder function is probably not going to change. So if by then you're still having stress incontinence, you want to look into other treatment options. And there's no great medication to treat stress incontinence, but working with a pelvic floor therapist to help strengthen the muscles can be beneficial. Those muscles can also benefit by putting some directed energy to the pelvic floor, like using the Emsella chair, which focuses electromagnetic energy into the pelvic floor to strengthen and thicken the muscle. One of my favorite patients who sat on the Emsella chair in my office wrote a wonderful review just because I felt like it was such an honest interpretation. She wrote something like, I started this therapy with a lot of hesitation because I really didn't think that just sitting on a chair could do much benefit for me. And I can't believe the improvement I've gotten. And I've heard that sentiment echoed from so many patients. Is this really going to work? And then after 6 or 8 treatments, they're like, I can't believe the immediate difference I'm feeling in the strength of my pelvic floor and in the control of my urine. But beyond strengthening our pelvic floor for stress incontinence, if that's not enough, then we're going to be looking at procedural interventions. So this might be something like minor surgery. An incontinence sling can be placed just under the urethra to keep it closed. Now, because a sling is permanent surgery, I don't recommend it until you're done having all your babies. Other patients might be a candidate for something called a urethral bulking, where we actually inject material into the muscle of the urethra and thicken it up from inside to help keep it closed. That one is not permanent. It usually needs to be repeated about once every 1 to 3 or 4 years, but it's a more minor office procedure, so it's a little easier to repeat. And then, as for overactive bladder, that women can experience after a delivery, but it tends to be less common. Where we really see it is as women age. So it might be starting in their late 40s, 50s, or continuing on. This can be treated again with pelvic floor strengthening or with the Emsella chair. It can be treated with bladder retraining, and this involves doing some pelvic floor exercises called quick flicks when you're in the middle of a bladder spasm to help stop it. There are medications that help reduce the number of spasms in the bladder. Beyond that, there are even advanced treatments for the bladder. Bladder Botox injections are very well tolerated, and I've done those for over a decade. Patients get much better results controlling urgency and frequency with bladder Botox injections than they do with medication. And they typically need to be repeated about every 4 to 6 months. Then there are also neurostimulation options in which we actually stimulate the bladder nerve to help it work correctly so the bladder isn't spasming so frequently. I just think a lot of women are truly unaware that there are so many treatment options for them, and that may hold them back from discussing it with their doctor. Let's talk about urine leakage during a few other specific activities. One is leakage during sex. Now, because I talk so much about sexual health, I am always asking my patients if they leak during sex. But even in women who come in to talk to us and say, hey, I'm not making it to the bathroom or I'm leaking when I exercise, they're often very hesitant to bring up that it's happening during sex. Because if these women are uncomfortable talking about urine leaks in general, it's even harder to bring it up if it's happening during sex. Leaking during sex is a huge detriment to women being comfortable during sexual activity. They certainly don't want to have sex with a new partner if they're afraid they're going to leak. And even in long-term couples, they don't want their husbands to know that they've had some leakage during sex. It's really embarrassing. But we need to get into the mechanism of why you leak during sex. Rarely do women only leak during the activity of sex. They're almost always having leaks at other times as well. So I need to ask them, is it leaking right as he's penetrating? Because that's more often associated with stress type of incontinence. Or is the leakage at the time of orgasm when the pelvic floor is giving off all these contractions? That's usually more related to overactive bladder. And both of those conditions will be treated in the same ways I previously discussed. Another type of leak I hear is when patients go from sitting to standing. Some of them will say, I just urinated on the toilet, my stream finished, and I stood up and had a little dribble. Other patients will describe, I'm sitting in a chair and I'll stand up for whatever reason and I'll just gush, I'll have full bladder loss. It just lets loose. The first one, when you stand up from the toilet and you've just leaked a little more, is really annoying. Some women will even say, like, as they wipe, they get a little bit of urine on their hand, or they stand up and a little bit drips down their leg. It's not a huge volume, but it's enough to really bother them. For these women, I want to check that their bladder is actually emptying fully when they do urinate and that they're not having any retention. I want to check to make sure they're not having any pelvic organ prolapse, where the bladder doesn't empty all the way because it's drooping down. And the final reason may be that when they stand up, the pelvic floor should be tightening and closing the opening to the bladder. And maybe it's a little weak and it's still letting a few drops come out as they stand. The second condition, having a large volume of leakage when you go from sitting to standing, is much more distressing. I'm still going to look at those same conditions. Are they fully emptying? Do they have any prolapse? What's the strength of their pelvic floor? But very often, I'm dealing with someone in this condition with a significantly weakened pelvic floor, where the pelvic floor just doesn't move at all. And sometimes I'll joke with them and I'll say, when you stand up, you leave your pelvic floor sitting on the chair. So the bladder's just wide open, and whatever volume is inside dumps out. So those patients usually need combination therapy, meaning pelvic floor strengthening and possibly some of the surgical interventions we've discussed to help close the bladder. So I hope this really helps women to understand what the role of a urogynecologist is and how we differ from a urologist or a gynecologist, and also bring some awareness to the fact that this is such an important field of medicine for so many women as we age, which means we're just going to need more and more urogynes as we get older. Thanks so much for listening to today's episode. No information from this recording is intended as a diagnosis or treatment for any disease. If you are enjoying the show, please subscribe so you don't miss any of our exciting episodes. And we love to hear from our listeners and would be grateful for your positive review. We'll talk next time.